Can I please ask the poster, the rapid podium presentation speakers to come up now? Can all 5 of you please come up? And while they're coming up, I'm just going to correct an error that I made before when I was introducing Grant. I was speaking about his prolific record of publication, and I understated his publication number by about 300. I said that he had, have a seat, published 33 papers, and it's actually 330. And he was obviously too polite and humble to correct me. Okay, so Emily Worrell is going to start on impaired heart rate response during brief 30% isometric hand grip in adolescents diagnosed with concussion.
Okay, hello. All right, so pediatric concussion, as we know, is a public health epidemic, but an objective biomarker of cortical neural damage remains to be elusive. In adults, the cardiac autonomic function is impaired in traumatic brain injury, and results from mild concussion as well are equivocal. A reactive model may enhance the ability to observe this neural impairment. However, current attempts to do so make it difficult to isolate the effect of brain damage. So short duration, moderate intensity isometric hand grip, what it does is it has a rapid increase in the tachycardia, which would provide insight into autonomic cardiac control. This rapid increase in heart rate represents primarily the cardiovagal mechanism independent of the sympathetic involvement. So the objective of our study was to quantify the impact of concussion in adolescents on the heart rate response during brief isometric hand grip. And I tested the hypothesis that concussions would result in an impairment of the reactive neurocardiac function in adolescents. So the study so far has recruited 5 concussed and 12 healthy age-matched control adolescents ranging from 12 to 18 years. Participants performed 2 30-second isometric hand grips at 30% of their max voluntary contraction with 60 seconds of rest in between. The heart rate and hemodynamic variables were recorded at baseline, such as mean arterial pressure, systolic, diastolic, cardiac output, and stroke volume, and they were compared between baseline and during isometric hand grip. The preliminary analysis indicates that hand grip actually evoked a significant increase in the heart rate response from baseline in the control participants, but not in the concussed. The control participants showed a 7 beat per minute increase to the 30-second isometric hand grip, whereas the concussed only indicated a 1 beat per minute increase to the same stimulus. These preliminary results reflect a reduction in the ability to remove cardiovagal heart rate constraint in concussed adolescents when compared to control. Therefore, this data further supports the hypothesis of neural cardiac dysregulation in adolescents diagnosed with concussion. Thank you.
Rachel Ho speaking about emotion-mediated executive function in adolescents with post-concussion concussive depressive symptoms.
Hi everyone, my name is Rachel Ho. Sorry, I'm very loud. So research suggests a relationship between cognition and emotion, such that individuals with depression often show a deficit in executive function. Executive dysfunction and depression are also symptoms of concussion. So the purpose of our study was to determine how post-concussive depressive symptoms might affect executive function. We were also interested in how emotional stimuli in the environment might affect executive function as well. To do this, we used a self-report measure of depression to split our group between groups of individuals with elevated depressive symptoms and those with average or normal levels of depressive symptoms. We did this in adolescents. We then had them complete a neurocognitive test, IMPACT, and then we did an emotional executive function task and an MRI. In general, what we found was that the adolescents with the elevated depressive symptoms actually didn't perform that differently from those with the average or normal levels of depressive symptoms. But we did find overall that the group did very poorly on IMPACT. At least 1 out of 5 participants fell below the 10th percentile for each of the 4 big cognitive domains that the IMPACT tests. We also found that on the emotional executive function task that they did in the MRI, behavioral performance was not quite different. We did see some physiological differences, so some differences in the way they sort of allocated their cognitive resources to areas in the brain. But more importantly, what we found was that we didn't see a lot of frontal lobe activity during this task, and we would expect frontal lobe activity for executive function tasks. What we also did see a difference between the two groups was that we tested their post-concussive symptoms before and after they went into the MRI, so before and after they did that cognitive task. And we found that while the group that had normal or average levels of depressive symptoms, their post-concussive symptoms stayed the same before and after, but those with the depressive symptoms, their post-concussive symptoms increased. So we don't know if maybe they just put all their effort into that one task and then were very tired afterwards. But we did see a number of other clinical differences between the group, and we can chat about that if you come by my poster. Thank you.
Thanks, Rachel. Penny Welch-West, and I'll just let you read her title there. Yep.
Okay, so my name is Penny Welch-West, and I'm a speech-language pathologist working at Parkwood Hospital in London, Ontario. And I thought on the way in this morning with all the fog that I was driving in, did anyone else have all that fog? I felt like it was really appropriate for today's topic about the patient's complaints about feeling foggy, because I sure felt that way this morning. The program evaluation that I'm presenting in poster form today was in partnership with Western University, and a co-author, Dr. Andrew Johnson, is actually here with us today. I did see him earlier, if he could just raise his hand. He's still in the room now. He flew the ship. It's by show of hands, how many of you are working in more of a return to play kind of capacity? By show of hands. And how many of you in more return to learn? Okay, and how many have a combination of those things where you're doing a bit of both of those things? Okay, so certainly the initial thrust of the concussion surge was really around return to play. I think we'd all agree it was really focused around return to play aspects. And I think we're getting there in recognizing the importance of return to learn, return to life. You need attention, you need memory, you need reading skills, and you need social communication abilities for life. And so it's really important, I think, we begin to shift to focus, hopefully funding will follow, on those aspects as well. And I used to blame Sidney Crosby, for my waitlist pressures, because when he had a legitimate problem, it meant that other people could seek treatment. And that's really what it's meant at my clinic, is that people do feel that they can seek treatment because Sidney Crosby had a legitimate issue. I would say we treat with a far less expense than Sidney Crosby's treatment would have taken. And in October 2012, the need for a return to school group was apparent to me. We needed to get students back to school in a timely fashion, needed to do that in a way that was responsive to their needs. And so I created an innovative return to school program that returns secondary and post-secondary students post-injury, predominantly sports-related injuries I see, back to the classrooms. Our return to school group runs in 7-week module. It's a module-based curriculum, and it's 4 times a year. I'm taking 7 to 10 students through that curriculum, and so graduating about 40 students each year, and it's facilitated by myself as a speech-language pathologist. It does address the very specific needs of students who are experiencing persistent concussion symptoms. So I'm not seeing the people that are doing very nicely and recovering very well. I'm seeing those who are persisting with problems. And what's really important to me is that we begin to move beyond simply guidelines and simple accommodations towards more treatment, and looking at attention and reading, written expression skills, word finding skills, technology, study skills, and most importantly, social communication. So it is unique in its model. It has a treatment focus, an emphasis on formal and informal pre and post measures. And we want to move simply from thinking about simple rest to recovery and to more cognitive-based stimulation with these students. So I do have, my poster is number 8. I have chocolate because it's the end of the day. And if you want to swing by, I will give you chocolate.
Can I just take care of it for you?
Would you? Yeah. So you can learn more at number 8 if you would. Thanks, guys.
Thanks, Penny. I haven't seen that tactic before. That's a good one. And now we have Melissa Panicia talking about mindfulness-based yoga in post-concussion syndrome.
So hi everyone, and thanks for having me. I'm a fourth-year PhD candidate with the University of Toronto, currently conducting my work at Holland-Bloorview Kids Rehab Hospital. I know Dr. Tatter, you just mentioned HRV databases, so for those of you who are working on that, I would love to talk more about that after. But having said that, there were a lot of things that were covered today which are particularly pertinent to my poster, and I kind of rounded out my PhD work in saying, okay, I'm interested in basic science measures, but so what? And so the so what is the functional piece. As an occupational therapist by background, I wanted to kind of merge those two things together. And as our previous presenter pointed out, we know that persistent concussion is an issue. We know that it has a mental health layer. We know that we've focused a lot on identification and assessment, but we don't know how to help. So I thought, let's apply clinical intervention that's been used in the chronic pain population and try it out with this population. So we did mindfulness-based yoga for 8 weeks for 45 minutes. This was a pilot study, so 6 youth between the ages of 13 to 18 enrolled, identified with persistent concussion issue, 2 of which had developed secondary mental health issues. And so what they did was they came in for a baseline, they came in post intervention, and then the 3-month follow-up. So what did I collect? In terms of those basic science measures, kind of the meat and potatoes of it was heart rate variability, and they were actually attached to a Holter monitor during the yoga intervention, and then outside of the intervention for 24 hours. So it's 11 sessions of 24-hour recordings of heart rate variability. I also collected things like self-efficacy, how confident they felt, participation in daily life, post-concussion symptoms, and physical activity repertoires. And I wanted to monitor how those changed across the trajectory of time. And so what I saw was the same trajectory or increases that I saw in heart rate variability, which remember is a good thing. Thank you, Chris. That's a good thing. We see the same change or trajectory of change in the other functional measures. So self-efficacy got better and was maintained at 3 months. The same thing was found for post-concussion symptoms, physical activity repertoire, and we see this matched across time. What does this mean going forward? There was no control, so this is very inconclusive, but I'm promised to continue this work after my PhD. And if you want to hear more, poster number 9. Thank you.
That sounds like a promising area of research, but will you be giving out snacks at your poster? Okay. So now Swapna Mailabathula is going to talk about a preliminary view of concussion policy in Ontario school boards.
All right, so I realize that I'm the last one standing between you and your break, so I'll try and make it very quick. So today we've heard a lot about the consequences of concussion, and that's really a conversation that has extended into the public sphere over the past several years. And so it comes as no surprise that there's been a movement toward trying to figure out what to do about it, and that includes policy. So what we are doing is evaluating policy. We're evaluating Canada's very first concussion policy, which was developed by the Ministry of Education in Ontario, and it's being implemented in all 72 school boards, or it's supposed to. So we're going to be evaluating that. How we're doing that is we're taking an integrated knowledge translation approach. So we're using information from our knowledge users through the process of our research. And we're going to be creating an evaluation tool to evaluate all of these policies that we are collecting. To create this tool, we're using a modified Delphi method approach, and that's 7 steps. And throughout this process, we're going to use the literature, stakeholder conversations such as we're having today, as well as an expert panel for feedback to develop and to finalize that evaluation tool. So far, that evaluation tool, as you might see on my poster number 10, has 30 items, evaluation items, and it covers things like communication, education for different stakeholders, including teachers, referees, students, parents, and guardians, as well as surveillance, whether or not there's a return to play plan and what those steps include, whether or not there's a return to learn plan and what those steps include, and so on and so forth. So far, what we've found is that there is good representation for education of teachers, of staff at the schools, of students, but not so much of parents and guardians, and definitely not for referees and trainers. So that's an area to improve upon. As well, echoing what's been said previously, is that there's really a lack for prevention strategies in schools. So hopefully what we'll find through all of this research is that we can really inform revisions for this policy and the different policies in the 72 school boards over the course of the next year. Thank you.
Right on time. So one more hand for all of the presenters. Thank you very much. And you're free to go.